So mycoplasma. As usual, I'm going to present to you a clinical case so you have an idea as to what are the things that we normally look for when we have to look at a case. And most of the cases are there from your book, and they are standardized cases. So give you an idea as to what's happening here. Well, you can see the very first word over here is fatal. So of course this is a microorganism, Mycoplasma pneumoniae, and it can cause fatal pneumonia in young adults. Normally young adults should not have pneumonia. Pneumonia typically is for extreme ages, too young, or children and adults. So if a young person has pneumonia, the chances are there's a compromised immune system, most likely HIV, cancer, or anything of that nature. So you can see from here, 18-year-old woman, and previously healthy. She comes to the hospital, and she has respiratory complaints. They do a chest X-ray and find pneumonia, and they pretty much start a course for antibiotic, and then again she runs a temperature. Her antibiotic was changed to macrolide or cephalosporin, and her condition continues to deteriorate. Many times we feel that a person comes in pneumonia, all you need is an antibiotic, and that should take care of that. But remember, with all these kind of different antibiotic resistance coming up, you have to make sure that you're using a proper antibiotic, number one, and you have to make sure that the bacteria that you are fighting is not resistant to that particular antibiotic. And you can see the typical case, her condition deteriorates, she has pulmonary infiltrates, bilateral pleural effusion, and then again eventually liver failure. 18-year young person going through after such aggressive antibiotic therapy, and with all the support, she has hemorrhagic pneumonia, multi-organ failure, and she dies on day 35. So you can see she was in hospital for about a month. They must have done all this kind of antibiotic. But also keep in mind that you have to have your mind open as to what are other causes of pneumonia. And remember, we talked about cell wall, and most of the antibiotics are working against the cell wall, so you want to make sure that you're using a right antibiotic. So what happens in this case is that she most likely had mycoplasmic pneumonia. So mycoplasma pneumonia is an important cause when all other causes of pneumonia are excluded in a young person. So you really have to do all those serological tests and make sure that you have as one of your differential diagnoses. Remember, if you see a case of a pneumonia, you have to look at what are the possible causes and want to exclude. It's just like a multiple choice question, so you're given distractors. There has to be one correct answer. So you want to exclude all other before you go and click that particular answer. And you can see that if you do not do that, you have a very serious consequences. You can have a young patient sitting in hospital for 1 month with such an aggressive therapy, multi-organ failure, and eventually causing death of that person. So that's one important thing for this particular area. The other review case, as you can see again, keep in mind respiratory system. Again, it happens to a young 21-year-old Chicago State University, oh, I'm just adding that up, it's not a Chicago State University student, because they are very careful, they're very watchful for their health, I'm pretty sure. She has a non-productive cough, pulse is high, and then again, the moment you see pneumonia in a young adult, it should ring bell. It has to be something very serious. So this time they do a good job, and they look for the antibody titer for mycoplasma complement fixation test. And then basically, you can see from here, she responds to erythromycin and then survives. So two different scenarios. Once you make the right diagnosis and treatment, and the other you miss something and it will cause patient a life. So the bacteria for concern today again is the smallest, very commonly asked question, the smallest free living bacterium. And the problem with this bacterium is, if you know, many a times we want to filter, for example, you want to filter a solution or want to filter a vaccine. And sometimes they use a pore size. So you can see 0.45 micrometer. So it is able to pass through that, like viruses. So also keep in mind that when you're looking at sterilization technique, if you happen to have, most of the pore sizes that we normally have are 0.5. So it's not going to take care of bacteria, especially for mycoplasma. The other important thing, as I just mentioned, because they were giving those 2 persons aggressive antibiotic therapy based upon the use of antibiotic in terms of stopping cell wall synthesis. Now the question over here is, there is no cell wall. So how could you be treating a microorganism for antibiotics? They are going to target cell wall where you have no cell wall. So that's another important aspect for this particular bacteria. It has a cell membrane that contains sterols and are unique among bacteria. That was a time initially, as the word suggests, most of the microbiologists thought that this was fungi. That's where the word myco comes from. Mycology. But it is a bacteria for all practical purposes. It has a slow rate of growth. Generation time is 6 hours. Strict aerobe. And what does it suggest to you if I say strict aerobe? Correct. So what's the implication of that? Respiratory diseases. Of course, a bacteria that wants to hang around at high oxygen content, it has the best possible place to locate. That's your respiratory system. That's why it was causing pneumonia. Okay? The other important thing, keep in mind when we talked about any bacteria that lodges in your respiratory system, and this system basically you have like 16 to 17 or 18 respirations cycle per minute. So the bacteria has to cling onto your epithelium very strongly so it cannot be pushed out, right? Because you are breathing in and breathing out. So that's actually a good mechanism, a cleansing mechanism, unless you're a chronic smoker or you are alcoholic, that destroys your ciliary ability to push mucus outside, okay? So bacteria comes with a virulence factor we call P1 adhesion, which is a protein that binds to cilia on epithelial cell, and basically that's how it gains access to your system. Very first important thing, keep in mind, in pathogenesis, the bacteria has to attach to those particular cells where these cells have to be invaded. And if your cilia are denuded because of chronic smoking, then again, you know, there will be a problem in this case because nothing can push mucus out of the respiratory system. A typical inflammatory response, release of cells, it is a strict human pathogen, and as been saying over again, maybe in the last couple of slides, I must acknowledge people for the American Society for Microbiology group people. They've been working with me on redeveloping and coming up with ideas. So you see some of the YouTube that's been put by ASM people, and in this case, NLAS. Okay, Mycoplasma species, you can see we have typical 2 species, M. pneumoniae, typically cause pneumonia, M. hominis. That's an important in terms of knowing because it's a normal vaginal flora. So this was some of the flora, commensal flora I wanted you to remember. What is the most dominant microorganism in vaginal microbial flora? Lactobacilli. And that's what that gives vaginal flora a pH which is acidic that will stop growth of any other bacteria that cause infections. Okay, so that's very important for you to know. And the other thing is, many a times, especially after vaginal delivery or even abortion, there may be an overgrowth of this particular bacteria of Mycoplasma where you may get post-abortal fever. So remember, many times your own normal flora is going to be transported up into the uterus or into where there is a lesion after abortion. So that kind of injury related area, this bacteria will grow and will cause problems. And again, some of the YouTubes, as I said, have been put for you to help yourself to learn some of the things which are here. So, as I said earlier, a size of mycoplasma is very important because most of the filters that we normally use are 0.5 micrometer. It happens to be smaller than that, most 0.45 or less, but you can see how it looks like over here. Now, since this is a bacteria that affects respiratory system, and we've been talking about gram-negative broad surface respiratory system, I'm just going to give you a comparative table. Keep that in mind. What are the characteristics? How would you compare mycoplasma versus other microbes? In these cases, you can see rickettsia, chlamydia, and viruses are the major bacteria or major microorganisms we can compare. So if you look at growth outside the host cell, you can see mycoplasma has an ability to grow outside the cell as compared to other which are considered as intracellular parasites. Because they are parasites. They need to grow, but they need to find a good cell. And these microorganisms will use your cell nutrients to find a growth requirement for their own growth. Independent protein synthesis. Viruses do not have, all of them have independent protein synthesis. Generation of metabolic energy, mycoplasma does have as compared to chlamydia and viruses. Chlamydia again is very close to viruses. We'll discuss chlamydia in detail. Does anybody remember what I said earlier in terms of chlamydia? What is it that it normally causes? Sorry? Number one STD in this country. Chlamydia infection is the number one STI, sexually transmitted infection, or sexually transmitted diseases, more than gonorrhea and more than syphilis. Chlamydia has been there for the last couple of years as number one STI in this country. So chlamydia is important. We're going to discuss that in detail when we talk of chlamydia, hopefully Monday. Okay, so rigid cell envelope. It does not have a rigid cell envelope. You can see from here where viruses obviously don't have. Reproduction by fission. So that's a typical normal binary fission division of any bacteria. So mycoplasma pretty much shares that characteristics. It's pretty much the same. What about the nucleic acid? You can see it has both DNA and RNA. Pretty much the same. Antibiotic susceptibility is there as compared to, but again, you have to find the right antibiotic to use. Okay, so you should expect, I would say, a couple of questions from this table because I want you to compare different types of bacteria with mycoplasma and want you to know why mycoplasma stands out a little bit different than others. If you were to culture this bacteria, we usually have two types of descriptions of the culture. One is, you can see from here, it looks like a fried egg. So we call fried egg Mycoplasma hominis. So fried egg appearance is for Mycoplasma hominis, that is a normal vaginal flora. As compared to Mycoplasma pneumoniae, you have mulberry appearance over here. You can see a mulberry appearance. And I would want you to look at some of the colorful picture that you may have in your textbook. So maybe you can more appreciate the mulberry experience. Okay. Structure. Again, as I said earlier, they are the smallest free-living bacteria. They do not have a cell wall. And then again, the most important thing that I want you to keep in mind is that especially when we talk of cell wall deficient bacteria, they are called L forms. So they are called L forms. They do not have sterols in the cell membrane and can form cells under the appropriate growth condition. So the most important thing is that the moment you think and you consider, oh, it doesn't have a cell wall. So if you use penicillin, cephalosporin, vancomycin, because they interfere with the synthesis of cell wall. Remember, I told you, you need to know where the antibiotics act. So you would rather use those antibiotics which act on the nuclear factors, for example. They act on ribosomes. They act on stopping nutrients to the cell as compared to these classical antibiotics that we've been using for gram-positive bacteria. And again, we did talk about the sizes. And I said earlier, I did say myco stands for fungi, but again, you can see we were struggling with placing these particular microbes either with the fungi or even viruses. So that was an initial challenge. But again, when you saw the comparison, if I was to ask you why this particular bacteria was not placed in viruses, so you can see viruses have a unique pattern. So viruses are a little bit different. Sometimes there's an overlap. And then again, many a times, if you do find changes, we can always change the nomenclature or classification factor. Okay, now they divide by binary fission. That's typical of all bacteria. They grow on all artificial cell media because they do have both RNA and DNA. So facultative anaerobic except pneumonia, which you just told strict aerobe. But of course, if you look at a strict aerobe, that's going to find a way in respiratory tract to get infected as compared to vaginal flora, where, of course, aerobes have no role directly. So it's an anaerobic, facultative anaerobic, and then again, you can grow it. It grows very slowly, and then again, since they do not have a cell wall, we basically are looking for some of the antigenic determinants, which are membrane, glycolipids, and proteins. So if there's no cell wall, you have a cell membrane. In cell membrane, we have these glycolipids that pierce the cell membrane because you have to serotype and you have to find out what are these antigens. The other important thing, immunological aspect for this particular bacteria is the antigens cross-react with human tissues and other bacteria. And remember, if that is the case, you're going to have cross-reactivity. So you'll pick up an antibodies, those antibodies are going to go for some other targets as well. Okay? Pneumonia is an extracellular pathogen. And again, I'm going to spend some time on P1 adhesion, which is most important thing. But before we do that, just keep in mind a normal physiological process where you have cilia on the epithelial cells, and these cilia are continuously pushing mucus outwards. So they kind of pushing. That's why when we say smoker's cough, so they keep on doing like this because their cilia is not working, so they have to voluntarily push the secretions out. So that kind of a thing we call smoker's cough continues there because of them losing the cilia. And if there is another problem with ciliated epithelium, we call ciliostasis. So the ciliary cells basically stay at one place, they don't kind of push around. It's just like if you want to swim without the flippers or without your hand motion, you cannot move. Exactly, that's the case to move mucus out of your system. Okay? P1 attachment, and you can see from here, this is a cilium, right? And then again, this particular is a glycoprotein receptor, which is there on the cell, and then attachment organelle or P1 adhesion. So you have a particular mycoplasma of the cell membrane, you can see from here, and this will attach to this glycoprotein, and that's what I mean P1 adhesion. So it attaches very firmly, so ciliary action would not be able to push it outside. So that's the most important thing in terms of pathogenesis. We call P1 attachment. Okay, the other important thing for you to look at, and it's going to be unique for this bacteria, which is called cold heme agglutinins. And I've been saying that over and over again, heme agglutinin and neuraminidase. I just wanted to prepare you for the viral infections. H1N1. H stands for heme agglutinin, N stands for neuraminidase. So these are serious receptors which are there. So IgM antibodies react with the antigen of human RBC, and they basically are 2/3 of symptomatic patients with pneumonia, especially mycoplasma pneumonia. So these are called cold heme agglutinins. This basically is considered, I just told you that The antigens are cross-reactive. So if you make an antibody, they react against the microorganism, but they would also react on some other human tissues, like in this case, red blood cells. That's where it is basically coming from. So you may have some problem with your red blood cell as well. But this is a non-specific immune response because the glycolipids of the outer membrane cannot be directly detrimental to the host. So it's a little bit non-specific as compared to full-fledged autoimmune disease. But again, having said that, maybe there are current papers and they may find out that it's more specific than what we are teaching today. Okay, now in this case, if you remember your immunology, if that is the case, then M. pneumoniae, the mycoplasma, may act as a super antigen because it's not restricted to one response. It has a cross-reactivity, so it will create that kind of a endotoxin, mediated diseases that we've been talking in previous cases. We have super antigen. So this super antigen basically is going to, like toxic shock syndrome, TSS, stimulating inflammatory cell to migrate to the site of infection, and then again you have Th1 type of cytokines which are pro-inflammatory. And this process basically, of course, if these cells will come, they will take care of bacteria, and they basically should be protective if everything is within normal range. If you look at epidemiology, no seasonal incidence, and primarily infect children between 5 and 15, and then again transmitted by inhalation by aerosolized droplets. So this is some of the important things that you want to keep in your mind, especially when you talk of epidemiology as compared to viral infections that you may see. Strict human pathogen, and then again some other bacteria or viruses should be there for your differential diagnosis. Remember, we've been talking about step pneumonia viruses. They also cause infections, but if you want to look at the age of the person and many other tests that we can normally do to make sure that we don't miss that. 2 million cases of M. pneumoniae and 100,000 pneumonia-related hospitals annually. So this is pretty much high figure by all practical purposes. But the good thing is that M. pneumoniae is not a reportable disease, and reliable diagnostic tests are not widely available. So that basically may not reflect the true incidence that we normally see. Okay. We did talk about the clinical disease. I just told you that most of the time, very extreme form will be pneumonia, but if it's lodges in the upper respiratory tract, we call it tracheobronchitis, and then you have these kind of typical picture. You can also have acute pharyngitis. Depends upon where those bacteria lodge in. Begin with the mouth, oral cavity, pharynx, acute pharyngitis. Go a little bit down, trachea, tracheobronchitis, bronchitis, and alveolitis, and then pneumonitis. That's typically pneumonia that we normally see. And then again, if you look at histology, you will see lymphocytes and plasma cells. Lymphocyte for the cell-mediated response, and plasma cells for antibody response, because plasma cells produce antibodies. One important thing that I want you to keep in mind, and many a time you will see as a distractor in your question, is that this kind of pneumonia is also referred as atypical pneumonia or walking pneumonia. So you may have pneumonia, you're walking with it. Normally it doesn't happen. If you have pneumonia, you basically are really sick. But in this case, we call it atypical pneumonia or walking pneumonia. And again, if you look at the patient's chest radiograph, you can see bronchopneumonia, and then more physical findings. People may have myalgia, pain in the muscles, and some gastrointestinal symptom, but there could be secondary complication, and these are important because you may have neurological abnormalities, meningoencephalitis, paralysis, and so on and so forth. So you can see, especially the younger patient, if you miss that, this particular bacteria will go and affect CNS. So that is very dangerous in terms of younger children and the involvement of neurological abnormalities. So the moment if a person has an infection and a person has a problem with the vision, problem with sensory system, problem with the higher mental functions, we would really be concerned and want to go and test them for this particular bacteria. Now you can see a typical pattern within weeks post-infection. Very first thing, like typical infection, you get malaise, you get pneumonia, and then you can culture bacteria. And at the same time, you can see you have a serum antibody complement fixation test that could be done later part. But the most important thing is cold agglutinin titer that will rise. So probably you can see even before malaise, you can pick up this particular bacteria, and that will be more stable in terms of the whole course of this infection. Again, you want to compare mycoplasma usually is compared with another microorganism which is called ureaplasma. So ureaplasma look like similar name, but ureaplasma basically is a genitourinary tract problem, especially Ureaplasma uroloticum, which enters into genitourinary tract and then basically causes urethritis, as compared to Mycoplasma pneumoniae, which enters upper respiratory tract, as I said earlier, depending upon where it stops, and then you can have a disease. If you want to compare different types of Mycoplasma, we just discussed pneumonia, respiratory tract, the symptoms. Mycoplasma genitalium, this is a genitourinary tract, and then Mycoplasma hominis, I just told you, for post-abortal fever, normal vaginal flora. And in this regard, I just want you to compare with another bacteria, which is a Ureaplasma uroloticum. Again, this is important because it basically affects both systems. It affects respiratory tract and it affects urinary tract. So non-gonococcal urethritis, NGO stands for non-gonococcal urethritis, and you can see it has pyelonephritis, spontaneous abortion, premature birth, and it does have a common prevalence in this country. How do we diagnose it? You can look at the different tests that we have. The most important is, of course, molecular diagnosis, but you can also look at serology. In serology, we look at the antibody titers, we look at cold agglutinins, and these are the most important thing, cold agglutinin and complement fixation, and then there are quite a few other tests available. If you remember, in the particular case, the second case, when the patient survived, they used erythromycin. So erythromycin remains as a drug of choice, and then doxycycline or other, and this is something important. If any infection does not give you a lifelong immunity, so that probably is not a good candidate for you to make vaccine against. That's what it is saying over here. Immunity to reinfection is not lifelong, and vaccines have proved ineffective. Doesn't mean that they're not making vaccine. They're still trying to make vaccine, but that is probably the reason. If I ask you why the use of vaccine is ineffective in treating mycoplasma, the answer is because immunity to reinfection is not lifelong. There's an answer for that. And again, you can read key points. Download them from Moodle, and pretty much will cover whatever I've spoken in the last half an hour. Okay, Actinomyces was the next bacteria. And many times, you see today's lecture theme is that these are the bacteria that had initially problem of placement. We don't know whether they were bacteria, fungi, or viruses. So many times, they gave them a name, and the name stood for a while. Because mycosis, mycology is fungi. So many times, Actinomyces, they probably initially thought that this was a fungi. And that's why you really need to be careful, especially for the distractors. But as of now, it stands that it's a gram-positive rod, which is a bacilli. It's a slow-growing anaerobic, and it has a yellow organic orange granule. So that's pretty much a common thing that we have. If you look at the characteristics, this is normally present in our GI tract. Do not produce disease unless transgress epithelial barrier, just like opportunistic infection. If you cut epithelial barrier, if you have ulcers, of course, it's going to go. And again, the most important thing for Actinomyces, and I'm going to show you some impact slide as well. The moment you think of Actinomyces, you think of a disease called actinomycosis. So immediately that should flash in your memory. And the most important thing, like TB, you will have sinus tracts oozing pus. And if you take that pus, look into the microscope, you will see sulfur granules. Right? So this is, again, we call it a hallmark of actinomyces infection. There is no evidence of a immunity infection in terms of protection, but again, of all the type of Actinomyces israeli, this is the most common thing that we normally find. Infection of cervicofacial area. Remember, for TB, we talked about lymph nodes in the neck, we talked about lymph nodes everywhere, very chronic disease. But if a patient comes with the upper part of the head, cervicofacial area, which is very common sight, many a time, the dentists deal with it. If you're not careful with your dental hygiene, right? And then again, there's tons of bacteria living in your mouth, poor dental hygiene, don't take antibiotics before tooth extraction, and just want to take your tooth out yourself. It may happen in many places that every other person is a dentist, because dentists do charge a lot. So in that case, actinomyces will be a major problem. But thoracic and abdominal, though theoretically present, are rare. Surgery, trauma, intrauterine devices may provide because you just have to understand the rule for opportunistic infection. Any abrasion, any challenge, any cut, any injury will make them go into your system. That's why basically very difficult to pick up, diagnosis delayed. People come with a very vague and non-specific symptoms. But if you look at the picture I'm going to show you, a typical, we call it lumpy jaw. Some of the features are unique. Some of the features are so unique that their clinical features are very prominent. There's no other diagnosis. They immediately start a therapy, empirical therapy. Cervicofacial actinomycosis, lumpy jaw with draining sinuses at the angle of jaw. This is a typical situation of cervicofacial actinomycosis, very common in Africa. Clinical diagnosis, as I said earlier, you can look at the nature of the lesion, very slowly progressive, history of trauma, and then again you will see mucosal invasion, like I told you, dental surgery or any other abdominal surgery where you mess up the mucosa, and then again this will go and penetrate. Diagnosis is complicated because, why is it complicated? Because mucosa has tons of bacteria anyway. So you really have to find out which is normal versus which is abnormal, and especially all your millions of friends sitting as a normal flora want to cause an infection, and you want to grow them on a plate. If there are 10,000 in the mouth only, so you have to have 10,000 cultures, difficult test. That's why we are coming with microbiome, which is basically looking at the genetics, genes of those bacteria, and we have all the data available. So that's like a better way of diagnosis. And then again, you can take the pus out, as I said, look into the microscope, and you should be able to see sulfur granules. If you want to look at the gram staining, slow branching rods, the branching was the thing in those bacteria that they initially thought that maybe it's a fungi, because branching is more to do with fungi. So it's like a typical tree-like pattern. So once we teach you mycology, you will appreciate that. Anaerobic culture is required, biopsy is characteristic, and then you can do incubation for a particular strain to find out if it's really growing in the system or not. The treatment of choice is penicillin G. You have to give high doses of penicillin. Therapy, long therapy, 6 weeks, and initial therapy treatment course, maybe you want to give like IV and then follow with oral penicillin for 6. So that's a unique situation. Normally you would say, well, one course of antibiotic suggesting maybe like a week or at the most 2. So that is a unique thing and very commonly asked as a differential diagnosis, as a distractor as well. What is the clinical condition where you want to use penicillin for 6 to 12 months? And the answer will be, of course, actinomyces. Okay? So imagine that situation of the cervicofacial actinomyces, and now another situation that you see, especially we call actinomycetoma. It's called mycetoma, basically. Mycetoma could be fungal, and mycetoma can be bacterial as well. So this one, if we say actinomycetoma, this is what it is. And many times, as I said, you must have heard me saying over and over again, our professor in University of Birmingham in England used to tell us that if you want to see a disease in very, very early form, you have to visit the hospitals in the West. And if you want to see a disease in very advanced form, you have to go to Asia or Africa. Because I told them at that time that they would have never seen third or fourth stage carcinoma of breast, fungating carcinoma like cauliflower. But we used to see that in Asia, very common, because people will come to the hospital in the end when all their so-called medicines will fail. So this is what is very common. I'm pretty sure those of you coming from that part, for many socioeconomic reasons as well. Just imagine for now that people don't have money to take one course of antibiotics. You want them to take antibiotic for 6 to 12 months. And then you will argue why the antibiotics are so expensive. They are expensive. Even your insurance is not going to cover it. You go and ask for it, very expensive. So how would you expect people in Africa and far off Asia and other countries for such a condition to wait for you to give them antibiotics? So that's basically we call socio-economical factors and some of the other conditions that are out there in terms of what we teach and what we preach and what we do. Anyway, so Nocardia is the last bacteria I'm going to touch upon today. And then again, they are in the same series of bacteria, because the idea is that we've been teaching you pure bacteria, pure viruses. I want to give you a historical perspective that sometimes we switch around because of the characteristics, right? And remember, when we talk of non-typable bacteria, what it means is we cannot culture them, we cannot type them, we have no serology, but we know for sure bacteria are there. So there's a challenge there. Just imagine you do a blood culture of a person and the person is sick and you want to start an antibiotic, but you cannot grow antibiotics. And those of you who have seen people doing blood culture, so you have 4 limbs, they will take out at least 20 cc from all 4 limbs to grow the blood culture. It's not like one drop. And even then, you are unable to grow bacteria. So these are some of the clinical challenges. And of course, I'm not teaching you clinical microbiology. I'm just teaching you basic microbiology. And then again, you will see a lot of things happening in that part. Gram-positive, rod-shaped, true branching. So that's where the confusion comes from. You've been so far told bacilli, cocci, coccobacilli, and we talk of some of like Treponema pallidum probably, then you'll see the little bit elongated. But when you see branching over there, you just get confused. And then again, you have to do many different things, but the branches are shorter, and most common human infection are from Nocardia asteroides and Nocardia brasiliensis, which are weakly acid-fast. And again, if you remember, what did I tell you when I was teaching you mycobacteria? I showed you that picture of piercing of that gentleman. What was the key word I said you have to remember with those piercing? You guys sleeping in my lecture, right? Mycolic acid. I said, look at mycolic acid. I must have said it at least 10 times. Mycolic acid. I said, keep that in mind because Nocardia has a mycolic acid, and there's a difference between the shortness of the chain of mycolic acid in Nocardia. And guess what? If I'm emphasizing things so many times, it doesn't take rocket science for you to know that it's going to come an exam. But I can tell right now, if you cannot answer me, how good your preparation is for the upcoming exam. It's April 10th, right? Is it 10th or 8th? So you don't even know the date. Interesting. Good. Well done. Okay. So this one is present in soil. I mean, I don't blame you. That's the nature of the beast. There's an exam every week. So it's like, just got immune to that. So many exams. You already have chronic inflammation going on. Tolerance, you already develop tolerance to that. I hope you don't develop autoimmunity and get sick. That's why fear is, but that's okay. So present in soil, and they are colonies that give aroma. So sometimes you take a wet dirt, you want to smell it. And remember, the smells, whether it's your, well, many times people have a bad smelling mouth. So that bad smelling mouth is because of bacteria. So the smell for bacteria, for secretion, anything that we'll discuss, sputum, vaginal discharge, urine, stool, so on and so forth, they are coming from bacteria. So that's what it is, aroma we call it. So that is coming from these pulmonary infections, because if you go and run and do exercise in that area, you can pick it up. Very bad for immunocompromised patient. And then again, they think there's no case-to-case transmission. But again, if you look at pathogenesis, the most important thing for nocardia lesion is the neutrophils. So neutrophils, if I tell you the neutrophils are the most important to take care of nocardial infection, so what do you expect the question that I'm going to ask you? Huh? I'm going to ask you. I'm going to ask you question on neutrophil immunodeficiency question, chronic granulomatous disease. That's what it is. Chronic granulomatous disease, where a patient have the ability to phagocytose bacteria, but unable to give to kill them. Again, you can see bacteria have the ability to resist microbial action of phagocytes. Bacteria are special. They relate to disruption of phagosome acidification. So they have the ability to resist oxidant burst. And pulmonary or brain infection is asteroides. And then again, dissemination to distant organ, particularly in brain. So two important things I just told you, though they look very simple bacteria, but if they go in brain, that becomes very serious. And again, it begins from skin infection because it's in the soil. And when we teach you fungi, I'll teach you many of diseases that come from one of the diseases called rose gardener's disease. For example, those people who handle roses, it's very specific fungal infection that these patients get. The important thing is that effective T-cell immunity is dominant, especially for nocardia infection. And then again, patients with impaired cell-mediated immune responses are greater risk for nocardiosis. Nocardia causing anything ending with osis, salmonellosis, legionellosis, that's where the disease comes from. If look at the pulmonary infection, is typically bronchopneumonia, can be acute chronic relapsing. It forms cavities. And then the typical symptoms are cough, dyspnea. What is dyspnea? Difficulty in breathing, dyspnea. Right? Dyspnea, dys means pain, painful in breathing. That's what it is basically. Dys means pain. Fever, bronchopneumonia, cerebral abscess. So that's a serious thing. A bacteria looks very benign, and you just pick up from the soil, goes into the lung, and makes an abscess in your brain. So anything that makes an abscess in the brain, you can imagine how serious that is. Skin involvement, usually see a pustule and a tender lymphadenitis. So the moment you see a lesion, you have to palpate the regional lymph nodes, because regional lymph nodes either be enlarged, painful, or they may be filled with pus, called pustular lymphadenosis. If you look at the diagnosis, basically easier than actinomycosis, of course, because the great numbers are present in the lesions. You have to look at the gram-positive rods, and then again, very weakly acid fast, but you can also run a blood agar test for them to grow, and you see the typical growing pattern over there. Okay, now, how do you treat it? There's another question. How do you treat it? Now, in this case, you can see from here, they are susceptible to sulfonamides. So that's the good news. Sulfonamides can be used. And this has been there for decades, and hope it stays unless they built up a antibiotic resistance. And then again, you can either give a sulfonamide alone or give a combination therapy with trimethoprim. And what we have seen recently, that most strains are relatively resistant to penicillin and other beta-lactams. So there's an ongoing study going on for this particular bacteria in terms of their outer covering, in terms of the cell wall, in terms of what's going on. So, so you can see that 3 different bacteria, right, that we were struggling to place them into different categories. So we discussed about Mycoplasma, Mycoplasma pneumonia, respiratory tract, Mycoplasma hominis, causing post-abortal fever as a part of normal vaginal flora. And I gave you one of the other examples of Ureaplasma, where I told you that Mycoplasma pneumonia is only restricted to respiratory tract, Mycoplasma hominis for the genitourinary tract, but Ureaplasma, ureolyticum especially, affecting both systems. Then we talked of actinomycosis, and as I said earlier, mycosis, it looked like a fungi, but it is a bacteria. And I told you the most important clinical picture for that, mycetoma. And I told you that there are many types of mycetoma. One is a fungal mycetoma that you see on that foot, a enlarged, swollen foot with draining sinuses, or bacterial mycetoma. And then we talked about nocardia, and I told you the most important thing in nocardia is that it has mycolic acid, and some of the mycolic acids basically resemble the mycolic acid of Mycobacterium because they have an ability to be acid-fast. So these are some of the things where you should learn how to compare and contrast. Okay? And I'll leave you here. I'll just make a few announcements, and then if you have any questions, then you can always come back to me. And